Nous allons reprendre nos travaux, s'il vous plaît. Nous étions déjà ce matin, quand nous sommes arrêtés dans la discussion générale du point 10 de l'ordre du jour. Et nous poursuivons donc les réactions des distingués délégués. Aussi voudrais-je donner la parole à la Tanzanie. Tanzania, you have the floor, please.
Thank you, Chair. Chairperson, Tanzania congratulates the Secretariat for the preparation of the implementation framework for the Africa member states, which is a guiding document following the adoption of the Global Strategy for Sexually Transmitted Infections 2016-2020 during the 69th World Health Assembly. Chairperson, sexually transmitted infections continue to pose huge health challenge in the African region. Though great strides have been made through the syndromic management approach in curbing the magnitude of STIs, their prevalence is still high. Prevention and control of STIs should be an integral part of comprehensive sexual and reproductive health services in order to contribute towards attainment of the SDGs and improvement in sexual reproductive health. Chairperson, barriers to STI control in Africa still exist, and these include access to diagnosis. A symptomatic nature of most of the STIs denies many people access to services, and very few countries have accurate diagnostic tests useful for diagnosis of asymptomatic infections. So while the syndromic management is simple, rapid, and inexpensive, it denies programs in low and middle income countries an opportunity to routinely monitor the specific infections, and syphilis and HIV, whereas syphilis and HIV remain the only STIs with inexpensive rapid tests. Secondly, antimicrobial resistance for some of the STIs, though still less common, is on the increase, and antibiotic-resistant strains of gonorrhea are a major concern, and particularly for the prevention of infertility in women. So there is need for countries' ability to monitor the resistance needs to be robust enough to avert this crisis. Thirdly, access to vaccines. One of the most common cancers affecting women today is cervical cancer, which is caused by sexually acquired HPV infection. Tanzania has implemented an HPV vaccination demonstration project, and we plan to scale up nationally in 2018. Fourthly, the issue of access to treatment. Improving access to treatment is also a crucial part of the STI response. However, we realize that in our country much more needs to be done, especially for the vulnerable populations and those people who are marginalized. Focusing on these high at-risk populations will lead to substantial individual as well as spillover benefits to the society as a whole. For example, the prompt management of STI reduces the risk of HIV acquisition or transmission. Chairperson, while the proposed regional implementation framework has described programmatic and policy guidance to member states to facilitate implementation of the strategy, we would also like WHO to provide leadership to countries to move towards dual HIV and syphilis testing. This will factor cost reduction in treatment. In conclusion, Tanzania supports the adoption of the proposed implementation framework. I thank you.
Thank you, Tanzania. Zambia, you have the floor, please.
Good afternoon. Thank you very much, Chairperson, for this opportunity to make, for enabling Zambia to make a statement regarding item number 10 on sexually transmitted infections implementation framework for the year 2016-2021. I also wish to commend the Secretariat for their hard work in compiling the report. Chair, Zambia adopted the syndromic management of STIs approach from the WHO in the 90s. However, upon realization of the many STIs that went undetected and therefore untreated using this method, there has been a move towards improved case management based on risk assessment and laboratory confirmation. We are happy to note this shift in the implementation framework, which is under discussion right now. We, however, feel that a lot of us will need support to improve our laboratory capacities. Further, we want to prevent, for prevention and control of STIs, Zambia has integrated STI management and other programs into maternal, neonatal, and child health, where screening and treatment for syphilis and testing, counseling, and treatment for HIV are now routinely done. Integration not only reduces missed opportunities, but we also feel it reduces stigmatization. The Zambian government, through the Ministry of Health, provides free healthcare services for HIV and AIDS, other STIs, and other related reproductive health services. In conclusion, the regional implementation framework addresses critical issues which, if implemented, could contribute to ending STI epidemics as major public health concerns by the year 2030 in the African region. Zambia, therefore, endorses the adoption of the regional implementation framework. I thank you.
Thank you, Zambia. Angola, you have the floor, please.
Obrigado, Senhora Presidente. Senhor Presidente, Excelência, Senhora Diretora-Geral da OMS, Senhora Diretora-Geral Regional da OMS, distintos ministros e delegados. Em Angola, à semelhança de outros países da região africana, as ISTs constituem um grande desafio de saúde pública. Neste contexto, concordamos com as questões e desafios apresentados no documento, sendo que a atenção maior deverá ser dada às questões de informação e implementação das intervenções preventivas e investigação clínica, laboratorial e epidemiológica. No que concerne às metas preconizadas para a região, são ambiciosas e para o seu alcance julgamos ser necessário reforçar o apoio técnico da OMS para os países, tendo em conta a realidade de cada Estado-membro. Senhor Presidente, Senhora Diretora Regional, no cumprimento das recomendações da OMS, Angola adotou, entre outras, uma abordagem sindrômica para gerir as ISTs. Nas consultas perinatais, as gestantes devem efetuar o rastreio para as ISTs assintomáticas, a avaliação clínica sobre sinais e sintomas. Relativamente ao diagnóstico e tratamento, está orientada a busca dos parceiros sexuais para o rastreio e tratamento de ambos. Senhor Presidente, Senhora Diretora Regional, minhas senhoras e meus senhores, o documento, em nossa opinião, reflete a real situação, levanta as principais preocupações e define de forma coerente as estratégias que devem ser adotadas, pelo que Angola apoia a aprovação do quadro de execução proposto. Muito obrigado.
Muchas gracias. C'est ça, n'est-ce pas? Thanks. Merci. Après l'Angola, le Gabon. Le Gabon, vous avez la parole.
Merci, Monsieur le Président. Le Gabon félicite le secrétariat pour la qualité du document d'orientation. Les résultats notoires mais insuffisants dans la région africaine en matière de lutte contre les infections sexuellement transmissibles justifient de reconduire et de mettre en œuvre une nouvelle stratégie mondiale contre les infections sexuellement transmissibles pour la période 2016-2021. Au Gabon, devant l'ampleur de l'épidémie des cancers, notamment celle des cancers du col de l'utérus, le gouvernement gabonais a construit un institut de cancérologie à Libreville qui constitue un pôle d'excellence dans le dépistage, le diagnostic et le traitement des cancers et une maison de vie pour l'hébergement des patients vivant en région éloignée. Ce Cependant, malgré les campagnes de sensibilisation et la distribution at large des préservatifs, vous conviendrez avec nous que tous les efforts sont vains sans l'introduction du vaccin contre le papillomavirus, qui, du reste, figure dans le plan mondial pour les vaccins, dont l'échéance est en 2020. Nous avons réalisé des études de faisabilité pour l'introduction de ce vaccin, mais son coût prohibitif ne nous permet pas de l'introduire pour le moment, car nous finançons à 100% notre vaccination de routine, n'étant pas éligible au mécanisme de financement Gavi. De fait, nous souhaitons avoir des objectifs pour la stratégie mondiale contre les EST plus ambitieux et des cibles plus bénéfiques pour la région africaine. Ainsi, pourquoi se contenter de 35 États sur 7 pour l'introduction du vaccin contre le papillomavirus dans la région africaine d'ici 2021, ce qui du reste sera en porte-à-faux avec le plan mondial qui demande l'introduction du vaccin dans tous les pays dans la vaccination de routine d'ici 2020. Acceptons-nous que des États, en particulier ceux à revenus intermédiaires, soient laissés sur le bord de la route, tout simplement parce qu'ils sont à revenus intermédiaires, et ce pour une question aussi cruciale que le contrôle des infections sexuellement transmissibles, dont vous nous avez largement décrit la lourde charge de morbidité. Vous comprenez que la question du financement de la vaccination s'invite encore et toujours, et s'invitera toujours à nos réunions, tant qu'une solution globale, équitable et pérenne ne sera pas trouvée dans notre région africaine. Aussi, le Gabon soutient-il la stratégie mondiale du secteur de la santé contre les infections sexuellement transmissibles pour 2016-2021 en demandant instamment que la cible de 35 États sur 47 pour l'administration du vaccin HPV soit reconsidérée, sachant que cette stratégie va servir de cadre de mise en œuvre et de mobilisation des ressources pour la lutte contre les infections sexuellement transmissibles. Nous vous remercions.
Merci, le Gabon. Je voudrais donner la parole au Congo.
Merci, Monsieur le Président. Nous tenons donc à féliciter le secrétariat d'avoir pris l'option de faire accouder cette stratégie mondiale au niveau du continent, même si cela se fait avec 12 mois de décalage. Nous tenons à rappeler que notre continent est confronté au risque élevé des IST, qui malheureusement touchent une population de plus en plus jeune, à l'image des grossesses précoces, ainsi qu'à certaines considérations culturelles. Il est important que le présent cadre prenne en compte les faiblesses des plans antérieurs, le plus souvent accoudés sur le plan contre le VIH-Sida, avec certes des bons résultats, mais certains très occultés. Ainsi, nos États attendent rapidement de l'OMS des appuis en vue d'approuver des stratégies nationales qui devaient prendre en compte ces faiblesses. Sur les mesures à prendre, nous souhaitons donc essayer de faire certaines propositions. Il faut donc intensifier le volet éducatif, comme on l'a dit, depuis donc en associant l'enseignement primaire et au sein de la communauté pour lutter contre les IST. Il faut lutter contre la pénurie des médicaments, car on constate de plus en plus les pénicillines de retard ne sont plus disponibles dans le traitement de certaines maladies sexuellement transmissibles. La prévention de la stérilité, comme mes prédécesseurs l'ont dit, dans le cas d'une meilleure prise en charge des infections à Neisseria gonorrhée et surtout des infections à chlamydier. La prévention, comme les autres l'ont dit, de la résistance antimicrobienne, qui inclut le contrôle des faux médicaments, puisque dans notre continent, la vente illicite des médicaments par les personnes non qualifiées favorise des automédications, ainsi que la prolifération des phénomènes de résistance, ce qui veut dire qu'il faut avoir une connexion entre les plans nationaux et le cadre stratégique régional de lutte contre les résistances, la coudée aux antimicrobiens avec le problème, la lutte contre les IST. Comme d'autres l'ont dit aussi, la prévention du cancer du col de l'utérus dans un processus de vaccination, que l'OMS et les partenaires deviennent mieux encadrés, car il faut un problème d'équité. l'objectif 35-47 pour nous ne semble pas fiable. Il faudrait que ce cancer soit mieux prévenu. N'oublions pas qu'il s'agit actuellement du deuxième cancer au niveau du continent africain, qui est souvent difficile à traiter. Alors il est important que la chaîne, la lutte contre les IST, implique tous les niveaux, depuis les postes de santé jusqu'aux hôpitaux de district, et soit toujours confortée dans le cadre des soins de santé primaires. Et bien sûr, comme il a été souligné dans ce cadre, la couverture sanitaire universelle favorise l'accès à toutes ces stratégies, qui doit, à notre avis, prendre en compte comme objectif, comme cela est souligné, l'élimination d'ici à 2030. Il faut quand même relever que dans les stratégies et dans les plans d'action de l'OMS, qu'il soit quand même pris en compte le problème de la stigmatisation de certains États, comme mon prédécesseur du Gabon l'a dit. Passer du stade intermédiaire actuellement au stade de pauvreté nous rend plus vulnérables au même titre que les autres États. Je vous remercie.
Merci, Congo. Je voudrais passer la parole au Burkina Faso.
Merci, Monsieur le Président. Le Burkina Faso s'associe aux autres pays pour féliciter le secrétariat de l'OMS Afro pour la qualité de la stratégie proposée pour lutter contre les IST et le cadre de sa mise en œuvre. Nous plaidons donc pour son adoption et profitons pour ajouter 3 contributions. Une sur les capacités diagnostiques, la deuxième sur la mise à l'échelle des interventions et la troisième sur le financement des programmes. La stratégie l'a bien démontré, l'approche utilisée en Afrique, l'approche syndromique est simple, mais elle conduit quasiment à un épandage d'antibiotiques qui est source d'émergence de résistance aux antibiotiques. Je ne vois pas dans le cadre de mise en œuvre un effort soutenu d'investigation pour mettre au point des outils diagnostiques simples qui peuvent révolutionner la prise en charge des IST. On a vu quel avantage nous a donné les tests de diagnostic rapide du paludisme qui ont permis de discriminer et de traiter que le paludisme pour protéger les médicaments limités que nous avons. Faisons la même chose pour la lutte contre les IST. Au niveau de la mise à l'échelle des interventions, il est clair qu'il y a des pesanteurs morales et socioculturelles qui font que là où les IST sont concentrés, je parle des populations clés, l'État ne s'investit pas vraiment pour lutter et endiguer les IST dans ces populations clés, qui est le terrain des organisations non gouvernementales, qui sont peut-être dans mon pays agglutinées en milieu urbain, alors que 80% de la population qui souffre de tous ces problèmes se trouve en milieu rural. Et donc, c'est un plaidoyer pour voir comment l'État, comment l'OMS peut accompagner les États à mieux s'engager dans la lutte contre les IST en ciblant là où les IST sont concentrés, les populations clés. La troisième contribution, c'est sur le financement. On a vu à peu près que le financement des programmes IST est dérisoire dans les pays, sinon inexistant. Étant donné la synergie des risques des IST avec le VIH, avec les hépatites, est-ce qu'il y a une réflexion que l'OMS peut conduire avec le Fonds mondial pour intégrer un volet de prise en charge des IST dans le financement des maladies et particulièrement dans les pays de la sous-région africaine? Voilà à peu près ce que le Burkina Faso a comme contribution et je termine en remerciant le président pour la parole donnée.
Merci, le Burkina Faso. I would like to give the floor. Ghana, you have the floor, please.
Thank you, Mr. Chair. The delegation of Ghana welcomes the report and commends the Secretariat for its stream of work on the global health sector strategy on STIs. The rate of new infections for the curable STIs presented in the report is staggering, and the challenges enumerated clearly explain the current state. Mr. Chair, the truth of the matter is that issues and infections related to sex are always difficult to address because traditionally we do not openly talk about sex. While lack of access of diagnostics and treatment remain a challenge, for some patients, the major challenge is the stigma attached to accessing treatment. The need to create conducive healthcare environments with well-trained healthcare workers who are sensitive to the needs and indeed the rights of people cannot be overemphasized. Ghana has set up STI and ART clinics within healthcare facilities for diagnosis, management, and STI education, which caters for the needs of all patients, including identified key population. These establishments give patients the freedom to discuss their health problems in the broader context of general healthcare delivery. In the same vein, Ghana is implementing an adolescent health and reproductive health program. This has led to the introduction of adolescent-friendly facilities within some healthcare facilities, which allows the young people to access information, education, diagnosis, and management of STIs without fear or discomfort. Education and awareness programs targeted at adolescents are also running in most of upper primary and secondary schools. Opinion leaders, such as queen mothers in our societies, are also empowered to educate the youth on STIs. Mr. Chair, Ghana commends the African member states that have introduced HPV vaccination nationally. It is an achievement worth emulating by all. Ghana is undertaking HPV vaccination on a pilot basis with plans to roll out nationwide. National research institutes in Ghana are also undertaking several research projects in STIs for effective management of infections, AMR, and drug resistance. Training and research are also being conducted in social aspects of STIs in adolescents and key population. Currently, Ghana, through our annual health systems support, is conducting a study in syphilis among pregnant women and prevalence of HIV among STI clients. Mr. Chair, a major challenge plaguing the efforts in addressing the STIs is inadequate financing. We hear this all the time because this particular challenge seems to permeate all health interventions in the region. For tackling STIs, we have come to rely on donor funds, which we all know is fast dwindling. Looking at the current trend, donor funds may not be increased in the near future. The question remains, what are we doing as member states of the African region to address this challenge? In view of scaled-up funding and other activities for HIV/AIDS, STIs are less talked about by member states and donors. All the attention seems to be on HIV/AIDS. Donor partners and funding agencies should begin to place more emphasis on STIs, just as is being done with HIV/AIDS. Ghana will appeal for increased domestic funding through adequate national budgetary allocations and pooled procurement for diagnostics and medication. Mr. Chair, these notwithstanding, I would like to congratulate the Secretariat for the Regional Implementation Framework and to support its adoption. I thank you.
Thank you, Ghana. Sao Tomé, vous avez la parole.
Obrigada, Sr. Presidente. A delegação de São Tomé e Príncipe quer felicitar o secretariado pelo brilhante trabalho e quer informar que, por razões de agenda muito preenchida, a senhora doutora Maria de Jesus dos Santos, a ministra de Educação e Saúde de São Tomé e Príncipe, não pôde estar presente nesta sessão. São Tomé e Príncipe realmente vê que a IST é um problema. E nós perguntamos por que, apesar de tantas sensibilizações, que as ISTs continuam a aumentar. Qual é a falha? Há distribuição de preservativos, há passagem de informações, mas por que as IST continuam? Eu acho que está na altura de nós pararmos, talvez fazermos um estudo, uma investigação, por que as ISTs elas continuam a subir. Não vamos esperar que a doença apareça, não vamos esperar que as nossas filhas apanhem a doença depois para nós começarmos a reagir. Há uma necessidade de nós sensibilizarmos cada vez mais, focalizarmos na prevenção. Eu sei que no continente africano não é fácil uma mãe chegar e dizer para a sua filha de 15, 16 anos: ai menina, tu tens que usar preservativo. É um tabu ainda falar do sexo, como disse o ministro de Ghana, é verdade, sobretudo no continente africano. Mas eu creio que é melhor nós tentarmos quebrar esse tabu do que depois estarmos preocupados com a doença. Talvez a sensibilização comece por nós próprios, os pais, encarregados de educação, as nossas adolescentes em casa, os nossos filhos em casa, os nossos jovens, sobrinhos, a mentalizá-los, a consciencializá-los de que é necessário, é importante ter uma relação sexual protegida. Se nós conseguirmos implementar isso na mente de cada um, talvez a gente não chegue ao problema de cura, de resistência dos antibióticos, de onde tratar essas doenças e de tudo mais. Obrigada.
Merci beaucoup, Sao Tomé. Nigeria, you have the floor.
Thank you, Mr. Chairman. I'm Regional Director, all other protocols observed. Sexually transmitted infections seem to have suffered some neglect with the advent of HIV. The report of a 2008 National Demographic and Health Survey in Nigeria indicated that 5% of women and 3% of men in Nigeria experienced a sexually transmitted infection and abnormal genital discharge or sore 12 months prior to the survey. Nigeria endorses the Global Health Sector Strategy on Sexually Transmitted Infections 2016 to 2021 framework and identifies its implementation as key to achieving zero new STIs, zero STI-related complications, and zero STI-related discrimination. To share our experience, Nigeria has taken the following steps: established integrated programs for the control of HIV and sexually transmitted infections, and including viral hepatitis at the national and subnational levels, with desk offices and funding streams established. National data capturing tools have also been reviewed to incorporate indicators for the monitoring and evaluation of tracking of the entire spectrum of care on STI programs led by the National Technical Working Group. Based on available data in the country, key populations, adolescents, and pregnant women have been prioritized for interventions for the control of STIs, especially for prevention of mother-to-child transmission of HIV and syphilis. New evidence-based STI management guidelines have been produced for implementation in public and private facilities. Nigeria has a robust system for effective supply chain management of commodities used in the management of HIV/AIDS, and this has been upgraded to provide the same quality services for STI commodities. Relevant drugs have also been captured in a national essential drug list, and the use of drug revolving scheme is being practiced. Our government is collaborating with the private sector to increase support for STI interventions, especially with local pharmaceutical industries in a public-private partnership framework. Nigeria is working towards including the care of STIs into the National Health Insurance Scheme coverage and incorporating HPV vaccination into routine immunization package for adolescent females. Our country has concluded a pilot on the use of dual rapid HIV syphilis diagnostic kit at antenatal clinics towards dual elimination of mother-to-child transmission of the two diseases. Our country has put up the following interventions to address treatment challenges and drug resistance, such as training of healthcare providers, scaling up health education within the facilities and communities, and so on. The need for local study to ascertain the level of antimicrobial resistance is being weighed. Laboratory capacities will need also to be strengthened in this regard. Further effort and cooperation is, however, required in the integration of STI, such as syphilis and gonorrhea, into epidemiological surveillance systems, as well as conducting antimicrobial resistance studies, promoting operational research in the management of STIs, identifying all opportunities for resource mobilization, especially for the HPV vaccination program, since it is very capital intensive, adopting and scaling up screening of HIV and syphilis in pregnant women using the dual rapid test kit, and building capacity of health workers in the management of STIs, particularly at the basic level of care. Thank you, Mr. Chairman.
Thank you, Nigeria. Botswana, you have the floor.
Thank you very much, Mr. Chairman. Botswana acknowledges the progress report on global health strategy on sexually transmitted infections 2016-2021 implementation framework for the African region. STIs are indeed a public concern, hence the global health sector strategy is indeed timely and necessary if we are to adequately respond as the globe. We in Botswana can associate ourselves with the issues and challenges highlighted and recognize that the implementation framework nicely addresses the aforementioned challenges. Strengthening STI surveillance remains key to ensure that our interventions are evidence-based. We therefore need to give this area great attention. Furthermore, strengthening of other components of the health system should be undertaken. We would like to see an integration of STI into other programs. We strongly believe that it shouldn't be a standalone. It shouldn't just be vertical. It makes economic and business sense to integrate. Chairperson, we continue to embark on high impact and comprehensive interventions to prevent, manage, and control the spread of STIs. To this end, I would just like to share what we believe as a key success area, which was the introduction of HIV vaccine for our HPV vaccine of our girls aged 13 to 16 years. We started the pilot in 2014. To date, we are probably close to 100,000 girls. We've achieved 97% success of vaccination of the population that is eligible. And therefore, in conclusion, we would like to associate ourselves with those that are saying let us adopt the implementation framework, because we believe that's the way to go. Thank you, Mr. Chairman.
Thank you, Botswana. South Africa, you have the floor.
Thank you, Chairperson. South Africa welcomes the implementation framework for the African region. It is vital that we increase our focus on STI prevention and management, including in the context of HIV, especially in Eastern and Southern Africa. South Africa has prioritized strengthening of interventions by, for example, including STIs in our latest national strategic plan for HIV, TB, and STIs, and it's the plan spanning from 2017 to 2022. The document by the Secretariat can be strengthened by 1. Referencing the utility of voluntary medical male circumcision in protecting men from certain STIs. 2. Emphasizing the importance of the prevention of antimicrobial resistance. 3. Additional information on the screening for asymptomatic STIs to be provided, including presumptive treatment. And then 4, including a section on the use of sentinel sites for monitoring, as it may not be practical to collect large amounts of information routinely. Some of the proposed targets may be difficult to measure. For example, 50% of key populations have access to a full range of services relevant to STIs, including condoms, since this presumes that countries have reliable size estimates of all the key populations. Thank you, Chairperson.
Thank you, South Africa. Angola, vous avez la parole.
Senhora Presidente, nós acabamos de emitir a nossa reflexão. Obrigado.
Merci, nous vous aimons bien. C'est pour cela qu'on vous a donné une deuxième fois. On va donner à votre voisin, l'Algérie. Merci.
Merci, Monsieur le Président. Chers collègues, honorables délégués, Monsieur le Directeur Général, donc l'Algérie, par la garantie de l'accès aux soins et aux diagnostics à tous nos concitoyens, a fait que nous avons réalisé de très grands progrès en matière d'IST. Il faut également donc insister sur le fait que nous avons un programme national qui est également soutenu par l'OMS, ce qui nous a permis de limiter la progression du VIH-Sida. Par rapport aux propositions que nous allons faire dans le cadre des IST, et afin donc d'alléger le fardeau que pèsent ces IST sur les systèmes de soins de santé et sur les sociétés touchées, et en vue d'atteindre les ODD dans la composante santé, il serait judicieux de maintenir l'engagement pour l'accès universel, ensuite concevoir et adapter les services en fonction des différents milieux sociaux, des contextes culturels et des besoins locaux, des actions éducatives et de conseils adaptés aux besoins des adolescents et des populations. Puis mettre en place des mécanismes pour lutter contre la stigmatisation, ce qui a été rapporté par bon nombre de mes collègues. Ensuite, il faut élaborer et mettre en œuvre un plan pour lutter contre la résistance aux antimicrobiens, particulièrement contre les antibiotiques, qui est une menace majeure qui impacte sur les IST dans le monde. Un cadre de son suivi et d'évaluation avec une allocation budgétaire spécifique nous semble plus que nécessaire. Enfin, je me permets donc d'insister auprès de mes différents collègues et des États membres pour adopter ce projet, et je remercie l'ensemble de mes collègues et des délégations pour leur attention et du temps qui m'a été accordé. Merci, Monsieur le Président.
Merci à l'Algérie. Uganda, you have the floor.
Thank you very much, Chair. Uganda joins other countries in thanking the Secretariat for quality paper on the STIs. And we also thank WHO for developing the Global Health Sector Strategy on STIs 2016-2021. As a country, we also have our health sector strategy on the STIs. However, a lot still needs to be done. As you are all aware, most of the African countries have a high challenge of the high teenage pregnancies that are evident in our countries, and also the child marriages. And these are children who do not yet understand what even the STIs are. So we need as member states to pay attention to these STIs because of the adverse effects that it has. And Chair, I just want to mention, we talk so much about cervical cancer and other challenges, but one problem that exists if the sexually transmitted infections is not treated is infertility, which we have not been talking about. Infertility has remained a matter between individuals, and yet it's a big contributor to domestic violence that we all know, and also even diabetes and other cardiovascular diseases from those who suffer from this problem. Because most of the infertility is normally blamed on women, and yet we all know that 50% of infertility is due to male factor. So I would appreciate, you can say, Chair, how the men are reacting. The women are normally blamed for this, and yet actually 50% is due to the male factor. So I would really appreciate if this is also incorporated in this document as part of the effects, adverse effects that arise out of the untreated sexually transmitted infections. As a country, Chair, we have an adolescent school health policy. We have rolled out the HPV vaccination to all girls aged 9 to 13 years. We have also, we are currently rolling out vaccination against the hepatitis B, which is also another challenge, STI, that we are currently experiencing. We have also integrated this STI treatment into our maternal and antenatal care services, and of course these are available in the hospitals. And Chair, I think I want to end there, since most of the other issues have been mentioned generally by the other speakers, by thanking WHO, and we support the adoption of this proposed implementation framework with those amendments. Thank you.
Merci. Sauf erreur, c'est le dernier intervenant. Est-ce que j'ai oublié quelqu'un? Non? Merci bien. Je voudrais me permettre de donner la parole au secrétariat ou à Dr Zawera pour l'éventuel complément.
Thank you very much, Mr. Chair, and thank you wholeheartedly to our honorable ministers and the heads of delegations for a very candid discussion about something that happens in our homes, in our houses on a daily basis, and has consequences elsewhere: sexual and reproductive health. Thank you very much for the guidance that you have given us, but I just wish to highlight a few issues that you raised questions on. As a globe, we are moving towards dual elimination of syphilis and HIV/AIDS, and therefore the pertinent issue that was raised about leadership around dual testing of HIV and syphilis becomes a very pertinent issue. At this point in time, I wish to inform the honorable ministers that the HIV-syphilis rapid test is now pre-qualified by WHO, and we have supported pilots of the use of the test in Zambia and Nigeria. Interim guidelines on the use of the test are available, and WHO is working on a definitive guidance. Although this is more expensive than the single testing of HIV or syphilis, the dual test will present an opportunity to integrate, as we have said, the syphilis testing, particularly in pregnancy. Delegates took the floor to talk about the strengthening of the lab capacity for AMR. I think if you remember from the presentation that RD made yesterday, that AMR is falling under health systems as well as communicable diseases, and hence we are hoping that as health systems are strengthened to look at AMR in its totality, the AMR vis-a-vis STIs will also be taken on board. You mentioned very clearly about integration, and definitely in the paper we speak to integration because we see that integration makes sense. Integration around adolescent health, integration around HIV programming, integration around SRH, MCH activities. But also I think there was a component about education, and hence that's why the document speaks to school health, where we need to get the information across to the younger people as they are growing up. I think you will be aware, honorable ministers, that HIV/AIDS is decreasing in other demographic groups, but it's actually increasing in adolescents, and that is ringing a big bell. That if our adolescents are having unprotected sex, they are going to have not just the STIs, but the HIV as well. Put that together and we have a can of worms, a serious problem that is waiting to explode. So the whole issue about focusing on adolescent health, focusing on comprehensive sexual education, focusing on providing services for adolescents. And I think I liked the communication in our own homes, because we are the parents of adolescents. And if we don't talk to them, if you remember yesterday during the cocktail, the group was talking to us about if we don't talk to them, guess who will talk to them? YouTube, Facebook, and anyone else, and they will get all the wrong information. So making sure that we put in place services, but also information for adolescents is particularly critical. I think there was a question around the targets for HPV. What we have put in the document is in line with what was agreed in the regional strategic plan for immunization. So we are just making sure that these two documents speak to each other. But I think the issue that was raised about the cost of HPV vaccination, we are aware of it, and therefore we are trying to see whether we can be realistic in the targets that we are setting. I think on the research for simpler diagnostics as RDTs, I think we have I have spoken to that. Co-funding for HIV, hepatitis, and STIs. As you are aware, there is no, in the Global Fund, in some cases, they do talk to the STIs, but not all of the co-infections around HIV. But I think this is where the information needs to happen, where in terms of providing services, we are going to provide them together. There was an issue about, which I thought was very pertinent, the private sector. If you think of where a lot of our people who are middle income and above, they don't come to the public sector for STI treatment. They actually go to the private sector. Hence, it is critical for you as governments to make sure that the same kind of guidance that is happening in the public sector also happens in the private sector. Otherwise, we have a divergent way of dealing with STIs. I wish to thank you again for taking that responsibility for the implementation of the framework, because it is with you that the implementation will actually happen. But we stand ready to support countries as you implement the framework. Thank you very much, Mr. Chair.
Merci. Je passe la parole à Madame la Directrice Régionale.
Thank you very much, Chair, and very briefly, because I know that the trip is waiting. I just first want to thank all the honorable ministers and heads of delegations for your comments, your contributions, the suggestions you made for strengthening this implementation framework, including looking again at some of the targets which some delegates thought were unambitious. So we will do that, and we will revise it accordingly. I just wanted to refer to the issue of middle-income countries that have graduated from Gavi prices, and suggest this is an issue that recurs in our discussions on immunization, and indeed we have noticed that some of these countries are struggling with their transition despite some of the mechanisms put in place by Gavi to help them. We think that this issue would benefit from a collective approach by the countries concerned. And as WHO, we are prepared to facilitate a dialogue with other partners who can perhaps help in negotiating prices, not the Gavi prices we've been told, but I have understood that it is possible to embark on a process if we are working collectively as a group of countries, therefore have a certain scale of a market to work on looking for more affordable prices, even if they are not quite at the level of Gavi pricing, while of course continuing with the advocacy which I think I'd like to understand needs to be at the level of the Gavi board. So perhaps those member states who are on the Gavi decision-making bodies represented here might also be approached in terms of the advocacy to help. We've had discussions with the Gavi Secretariat on several occasions and also with our colleagues in headquarters, and we think one step might be to ask these countries, and I'm willing to try to facilitate a brief meeting here, if we can identify the countries that are in this category, to start to have a discussion about how to work together collectively and look for help in relation to getting more affordable pricing, even if it's not quite at Gavi level. So we will be approaching the countries concerned individually, and if we see enough interest, we can facilitate a side meeting somehow and start this conversation together with our colleagues from headquarters and perhaps approach UNICEF and others who might help. Thank you very much, Chair.
Merci, Madame la Directrice Régionale. Distingués délégués, pouvons-nous considérer que le comité régional est disposé à adopter le cadre de mise en œuvre défini dans le document AFR LC 67/7 intitulé Stratégie mondiale du secteur de la santé contre les infections sexuellement transmissibles, période 2016-2021. Cadre de mise en œuvre dans la région africaine en tenant compte de toutes les observations et suggestions faites. Il en est ainsi décidé, le cadre de mise en œuvre dans la région africaine est adopté. Nous avions ce point. Merci. Ce point était l'un des points principaux de cet après-midi. Mais avant de conclure, je voudrais donner la parole à notre partenaire Gavi, qui est ici représenté par Madame le ministre de la Santé de la Côte d'Ivoire.
Je vous remercie, Monsieur le Président. C'est juste pour, par rapport à l'intervention tout à l'heure de Madame la Directrice Régionale. Effectivement, je suis membre du conseil d'administration de Gavi et je représente la zone africaine et lusophone. Donc, je voudrais rebondir sur ce que vient de dire Madame la Directrice. Je serai prête à ce qu'on puisse se retrouver avec éventuellement des membres de Gavi qui seront dans l'assistance pour que nous puissions voir comment nous pouvons apporter notre appui à tous les membres qui ont des difficultés dans ce domaine. Voilà l'information que je voulais apporter. Merci.
Merci Madame le ministre. Je crois que cette rencontre est opportune et c'est sûr que nous pourrons trouver du temps dans notre agenda pour être à vos côtés. Maintenant, j'ai quelques annonces. Il y a une réunion des ministres de la Santé de l'Union africaine en tant que groupe de travail du comité technique spécialisé sur la santé, la population et la lutte contre la toxicomanie, qui est donc prévue ce jour à 18h30 dans la salle Kalala Room. Cette réunion permettra de délibérer sur le projet de cadre juridique de l'Agence africaine des médicaments. Comme deuxième annonce, demain à 7h30 dans la salle Kalala Room, toujours de l'hôtel Elephant Hills, il y aura un petit déjeuner de travail sur le thème surveillance et certification de l'éradication de la poliomyélite dans la région africaine. Avant de conclure, je voudrais donner la parole au secrétariat pour d'autres annonces à faire, éventuellement. Le secrétariat signale que nous avons bien travaillé. Il n'y a pas d'autres annonces que de vous souhaiter un bon après-midi pour ceux qui ont accepté d'aller faire un petit tour au niveau du lac. Je ne connais pas très bien le nom du lac, mais vous verrez bien. Mais sinon, je voudrais vous rappeler que nos travaux vont démarrer à 8h45. Je vous remercie de la ponctualité comme ce matin. Nous sommes donc parvenus au terme de nos travaux. Merci.
Thank you. Merci beaucoup, Chair.
Through you, Chair, Honorable Ministers, Head of Delegations, may I request that we quickly move to the coaches that are waiting to take you to the boat. Please remember to carry your ticket. Without that ticket, the boat crew will not let you on because that's how they manage the numbers.